Hello, everyone, and thank you so much for joining our legacy event, Generating Sustainable Human and Institutional Capacity in Malawi. I'm Elizabeth Marino-Costello, Senior Program Manager with the Nutrition Innovation Lab at Tufts University. It's been my utmost privilege to have been with the lab since the start. I'd like to acknowledge at the outset how supportive USAID has been, both in Washington, D.C. and in Malawi, for all the activities we're going to hear about. I would particularly like to thank Malawi's Ministry of Health, in particular, Dr. Felix Phiri and Janet Guda, and of course, our AOR in USAID, Violet Orchardson. A special thank you to our colleagues in the video, especially my fellow newly practicing registered dietitians, for introducing the Nutrition Lab's 3 unique capacity building activities in Malawi. These activities are linked somewhat, but still distinct. The launch of the very first master's and diploma degree programs in clinical dietetics, the creation of the very first Malawian food composition table, and the creation of the very first nutrition framework for the medical school curriculum. We will hear today how the Nutrition Innovation Lab's 3 activities were designed in response to the health challenges identified in the strategic priorities by the Malawian government. In other words, these were activities generated to meet an expressed demand from the country level. That is so important for the best practice in the development and also for promoting the sustainability of activities and impacts. Our panel will share lessons learned in that process and describe how partnerships locally in Malawi and also regionally in the Eastern and Southern Africa will provide long-term success and sustainability for each of our activities. We will also share some what I call not so usual experiences associated with launching capacity building projects. For example, to help establish an actual dietetics program in the Malawian hospitals, our in-country team took a contingency of colleagues from the Malawi ministry and set out on a 2-day fact-finding mission, traveling to the University of Cape Town Medical Center in South Africa to actually observe the operation of their clinical nutrition dietetics department. And then there was the opportunity our students had to teach nutrition classes to the nursing students as a result of our initial partnership with the Malawi School of Nursing on a professional ethics workshop. And I can't forget about the never before opportunity to have actually a registered dietitian, the first, to collaborate on the development of the Malawian national guidelines for healthcare feeding. We are looking so forward to hearing many more of these stories from our panel. Our first speaker is Sanele Nkomani, a seasoned registered dietitian who led our in-country dietetics activity. Sanele earned a master's degree in nutrition from the University of Stellenbosch in South Africa, and her career has focused on developing clinical nutrition practice in East African countries, as well as developing national clinical nutrition practice guidelines, and instrumental in establishing in-country dietetic associations, which she's doing for Malawi right now. She has been a true leader, definitely, in building partnerships, engaging with policymakers in Malawi, bridging the knowledge gaps between scientists and policymakers. In other words, she has been really a key factor in our success. And so too has Bernadette Chimera-Khombe, the second speaker this morning. Dr. Bernadette is our clinical coordinator. She graduated from one of our partner institutions, the College of Medicine in Malawi. With Sanele, they teamed up. Dr. Bernadette has shaped our supervised practice in the hospital and has taught all of our dietetic students. Also joining the panel is our colleague and partner, Dr. Alice Kalimbira. Dr. Kalimbira earned his PhD in applied human nutrition from the University of Guelph in Canada. Dr. Alex is an associate professor and head of the Department of Human Nutrition and Health at Lilongwe University of Agriculture and Natural Resources. He is in the front line of implementing both the postgraduate diploma in clinical dietetics and the new master's degree in dietetics. Our speakers will have 10 minutes to speak, and then we'll open the session for questions. So Sanele, over to you.
Thank you, Liz, for that very kind introduction. So my part of the presentation will take you through an overview of the nutrition situation in Malawi, building into why these three activities were so important and really game changers in Malawi. And I'll take you also through some key highlights and milestones of each activity. Next slide, please. So starting with a snapshot of the burden of malnutrition in Malawi, and I frame these challenges as persistent and emerging challenges. The persistent challenges are those that have received significant attention in policy and interventions. For example, stunting, which is an area where Malawi has made significant progress in reduction over the last decade or so, is now currently at 39%. Wasting has virtually been eradicated as a serious problem or as a serious public health concern in Malawi at a prevalence of 1.3%. And iron deficiency in women of reproductive age remains a major challenge. And I've just used that as a proxy to other micronutrient deficiencies, which remain a major challenge where progress has been limited. So that's a picture of both success and some areas where progress is required. Emerging challenges are areas which have not traditionally been prioritized in policy and interventions, but are gaining more attention now. Examples of these are obesity and diet-related NCDs, which are on the upward trend in Malawi, with little or no progress made. I would like to highlight the obesity rates of women of reproductive age, which are at about 9.1%, and the rates of high blood pressure and diabetes, as you can see, are emerging and quite high. Finally, I would like to talk about a challenge which has received even less attention in Malawi, and generally I can say the same for Africa in general, and that is hospital malnutrition. Next, please. Although limited, data and evidence shows that the prevalence in Malawi could be around 60 to 80% of hospitalized patients, which is well above the world average. And the importance of this is that hospital malnutrition is highly correlated with worse outcomes in hospitals and death even. So it is quite an important indicator that has not received the due attention it deserves. Next slide, please. Building on the previous slide and the three activities in Malawi, just wanted to highlight that these three activities were a direct response to gaps identified by the government strategic plan, which identified nutrition capacity as a major constraint to delivering impactful policy and interventions. So the training of dietitians, the review of the nutrition content of the medical curriculum, and the development of a food composition database directly responded to strategic priorities set by the government to improve the response to the growing burden of the NCDs, for example, that I've just explained, and improve the disease-specific nutrition management, particularly in hospitals, which was virtually non-existent prior to this program. This is shown by the fact that there were virtually no clinical nutrition services in most hospitals, as evidenced by the lack of universal screening and assessment of patients and inadequate nutrition support resources as well. Next slide, please. Delving deeper into the skills gap that was filled by dietitians, it is important to understand the landscape of nutrition training in Malawi prior to this program. This was dominated by the nutritionist cadre, who are and have been instrumental in tackling the burden of malnutrition. However, globally and in Malawi, nutritionist training is not well standardized in terms of curriculum content and competencies. And generally, competencies related to disease management, including NCDs, have fallen outside of the scope of nutritionist work, who are better suited for more public health work. Dietetics training, on the other hand, is by nature standardized and uniform in content owing to stricter regulation of the profession. And this is usually done by national bodies who license and professional practice. The dietitian cadre has strong clinical and public health skills, which makes them quite versatile and adept at working at addressing both the persistent and emerging challenges at different levels of healthcare. Next slide, please. The second activity, the review of the medical curriculum, came from the perspective that doctors are actually frontline nutrition workers. And I say this because often they are the only point of reference for nutrition information for patients. Yet we know very little information, and we have made very few attempts to systematically address what they learn in medical school in terms of skills, nutrition skills, and knowledge. This is a global problem, probably more acute in Africa. And using an example of surveyed doctors in Ghana, it is clear that the doctors have serious reservations about their own competencies in nutrition. They were citing significant barriers such as inadequate knowledge and counseling skills, inadequate nutrition education in medical schools, and lack of an enabling environment for practicing, looking specifically for the resources for nutrition practice, including food composition tables and dietitians that they can refer patients to. Next, please. Given that there is just one medical school in Malawi, this activity was an attempt to systematically review what doctors came out of medical school knowing about nutrition and how well medical school prepared them to deal with the prevailing country challenges with the aim of developing recommendations to strengthen the curriculum. Next slide, please. Moving on to our third capacity building activity, the development of Malawi's food composition table. I'll start with why food composition data is so important in the first place. It is important for nutritional assessment, both individual and population level. And one example of population level applications is food consumption surveys, which have never been done in Malawi. Also, it is important for nutrition research, and I think my colleague, Dr. Kalimbira, will speak to some of the applications of the food composition table that have been used in research in Malawi. For dietitians and other health professionals, food composition data is a tool that is crucial for delivering dietary guidance at individual and population level. Another application at population level is that it has the potential for the development of food-based dietary guidelines that will target nutrition challenges or directly target the nutrition challenges of the country. Again, this has never been done or has not existed in Malawi. Food composition data is also a tool for planning therapeutic nutrition interventions, which are used by dietitians as well. Next, please. Some key information to know about the database, and that will be elaborated in the next section of the presentation where we talk about lessons learned, is the fact that a good chunk of the data already existed from publications and theses that were found in academic libraries and also from the food industry in Malawi. So quite proud that about 63% of this data was already here in Malawi, and was just a matter of putting it together. Next slide, please. So highlighting the milestones for each activity, I'll start with the dietetics program. And here we're very proud of how things have evolved from first the accreditation of the program in 2016 to the first intake of students in 2017 and subsequent graduation of those students in 2018. Particular area that we're proud about is the employment of our graduates in 2019, which was particularly significant because they were the first dietitians to be employed in newly created dietetic posts in the government of Malawi. So the second cohort, as you can see, began in 2018 and graduated in began in 2018 and graduated in 2020, and also were recently employed. And you can see that top picture is the second cohort versus the first cohort. And this is clearly showing some growth even with the number of students that we're managing to recruit. Next slide, please. So more milestones on the road to the development of the food composition database, which began in 2016 with the scoping phase and involved desk reviews to assess the nutrition landscape and the actors and stakeholders in the country. The collection of nutrient data was a longer process that involved training Malawi's food composition data compiler and key government staff. So that was a key capacity building part. And this was followed by a data quality assurance phase that followed FAO and in foods data quality standards, which was also a point where capacity was built for data generators in the country. Finally, the completion of the database, which we call MAFoods, in 2019, and the launch of it as well in 2020. And you can see at the bottom there, the bottom picture is just a picture of the data compilation team. Next slide, please. Finally, the medical curriculum. Key milestones were the development of the adaptable framework of standards for nutrition in medical education. And this is, to our knowledge, the first tool of its kind that has been used to assess the nutrition content in medical curricula. It is the result of an extensive literature review process and expert consultation on the fundamental nutrition knowledge skills that must be taught in medical school. The framework was then used to assess the existing medical curriculum, which culminated in a report of findings answering the key questions about what nutrition content is being taught and how it's taught, and all the how it's assessed, and all the questions that I'd outlined previously. A second survey to determine the knowledge, attitudes, and practices of doctors, or practicing doctors rather, on nutrition has recently been finalized, and we expect that these findings will be published in peer-reviewed journals. Next slide, please. Finally, the achievements of the Innovation Lab would not have been possible without partnerships formed and collaborations with local and international institutions. So here I just want to highlight the core partnership, which was with the Lilongwe University of Agriculture and Natural Resources, Luwana, and the Kamuzu University of Health Sciences, which was formerly known as the University of Malawi College of Medicine. Other key partners came into the fold. The government of Malawi, which we've highlighted just now, was a very important key stakeholder. We had partnerships with other NGOs, and we've given the example of FHI 360, but many other partners that we were working with. We had UN partners. Within Malawi, we had regulatory partners like the Medical Council that accredited the dietetics program. And then we also made strong partnerships with academic institutions in the region that filled important gaps, like the University of Cape Town and the South African Medical Research Council. So with that, I would like to hand over to my colleague Bernadette, who will talk more about the lessons learned. Thank you for your time.
Good. Hello again, everyone. Sorry about that. Thank you again for joining us. I am Bernadette Chimera-Khombe, and I will be sharing with you the lessons learned in implementing these 3 activities. Next. So, as earlier mentioned, this was a unique project which led to 3 unique flagship outputs, which was the first dietetics training program in Malawi, the first food composition database in Malawi, and the first ever specific review for medical nutrition content in the medical curriculum. So it was therefore inevitable that a lot of lessons would be learned along the way. Next. A key lesson that was learned across all 3 activities was the significance of early sustained stakeholder engagement. Next. And this process of stakeholder engagement began with accurately identifying who our influencers and decision makers were, and these were the Ministry of Health, and in particular it was the Department of Clinical Services and the Department of Nutrition and HIV/AIDS, amongst others. For the dietetics program specifically, we went on a campaign of raising awareness and sensitizing stakeholders on the gap that dietitians feel in clinical care. We also kept the stakeholders engaged using site visits to hospitals with senior government officials to show them how registered dietitians fit into clinical practice and the consequences of their absence. And through these strategies, we received positive response from the government, which has led to the establishment of 27 government-funded posts created specially for dietitians. And as shown in the slide, you will see one of the 11 graduates who is now employed by the Malawi government working in ICU as a registered dietitian at the Kamuzu Central Hospital. We also believe that the creation of this post contributed to the growing interest towards the academic program, as we have seen through the 3-fold increase in applicants from the first to the second cohort. And for the food composition database, engagement of stakeholders also included site visits and capacity building through the help of the South African Medical Research Council. These visits included staff from the Department of Nutrition and HIV/AIDS as the government hosts of the database. This allowed the hosts to appreciate the necessary efforts and resources required to house the food composition database, whilst simultaneously updating it and promoting utilization of the tool. In this picture, I'd also like to show you one of our recent stakeholder engagements where the database was presented at the Scaling Up Nutrition 3.0 launch with the President of Malawi, Dr. Lazarus Chakwera, learning more about the table and its utilization from one of our team members. And for the medical curriculum review, the other slide. Yeah. For the medical curriculum, we appreciated the need to have the buy-in from the university as a stakeholder in order to prepare for the acceptability and adoption of the findings of the review. Next. Another one of the lessons that we learned is the need to leverage strengths of local, regional, and global partnerships to develop and implement quality programs. Let me begin with the dietetics program. This program was built on the collaboration between the Lilongwe University of Agriculture and Natural Resources and the College of Medicine, now known as the Kamuzu University of Health Sciences. These two brought together their respective strengths to build a quality program. And I must emphasize that at the start, no one institution in Malawi had the sole capacity to implement all the parts of the dietetics program on their own. And this was the same with the food composition database. And so in implementing all three of these activities, international partners, who in this case were Tufts, came in with content expertise, leadership, and coordination. Next. I should highlight that through this project, we learned of the existing regional capacity that has now been strengthened into a network of African nutrition human capacity. Specifically, I must highlight the support from the University of Cape Town, who took our students on a 6-week practical rotation to practice with nutrition resources that are essential for dietetics practice, but not currently available in Malawi. Next. Next, please. Yeah. I should also recognize the South African Medical Research Council for their technical expertise and contribution to the development of the food composition database. And let me also highlight the very important role that very experienced Malawian nutrition professionals played in taking ownership of these three activities. Next slide. The third overarching lesson was implementation of a targeted response to national needs. In Malawi, we took several steps to understanding the context, starting with scoping visits to map out stakeholders and how nutrition and health programs are delivered. We also carried out an extensive analysis of the national nutrition and health policy and strategic directions, and identified where each of these activities could contribute. In particular, for the dietetics program, a needs assessment was conducted to ascertain the need for the dietitian and the need for nutrition support in healthcare. This targeted approach was complemented by the stakeholder engagement. And as a result of these actions, we believe this program responds directly to the needs of Malawi, which we identified to be the need to generate nutrition human capacity and evidence, while simultaneously improving the enabling environment for nutrition practice. Next slide. And now lessons specific to the curriculum review. There are not a lot of medical curriculum reviews of this nature that have been done in Africa. And so we're proud to be the first. Because this was one of the few, the first lesson we learned was the necessity for standards for assessing nutrition gaps in medical curriculums. And so this led to the development of an adaptable framework of standards for nutrition, as Sanele had mentioned. And this is what we used. The framework particularly covered 4 domains, including basic nutrition principles and practice skills, nutrition across the lifespan, and a category termed as others, which we included nutrition support, nutrient interaction, and nutrition in palliative care. Upon completing our review, one of the striking lessons was the evident gap in application of nutrition knowledge in clinical practice years during training. To explore and support this, we conducted a survey which assessed knowledge, attitudes, and perceived self-efficacy in medical nutrition practice for doctors in public service in Malawi. And this also showed a gap in knowledge and application, demonstrating that the longer one was in practice, the lower their nutrition knowledge score and the lower their confidence in nutrition practice. And this therefore led us to our last lesson on this, which was the evident need for nutrition curriculum task force to champion medical nutrition education and reinforce nutrition skills in practice through in-service trainings. Next slide, please. Finally, the food composition database. With the food composition database, the first positive and encouraging lesson we learned, which Sanele had started to explain, was the possibility of using locally generated data and local capacity to develop Malawi's first food composition database. With 125 foods coming from locally generated data, this speaks volumes to the sustainability of this database, knowing that local researchers will continue to update and utilize this tool even after this project. We also gained from the existence of regional data, particularly where we encountered missing data. In these instances, the foods were matched with a similar food in other selected food composition databases, whilst of course correcting for moisture differences. And the 3 regional databases that were used for food matching and borrowing were from Mozambique, West Africa, and South Africa. And beyond Africa, we used the United States Department of Agriculture Nutrient Database. The rationale for the selection of food for matching was comparability, followed by the nearest geographical setting of the matching source, and finally, reliability with respect to the data quality. And data quality was one of the challenges we faced. Many articles and scientific reports did not meet quality criteria for compilation. For example, there was ambiguity in food description, and in some cases, analytical methods were inadequately described. And so to curb this, we held data quality workshops so that Malawian researchers may be aware of the criteria required for their data to be admissible in the next versions of the database. Additionally, we also proposed that moving forward, that there would be introduction of food composition database modules in universities where this is found to be relevant. So overall, there has been some immense learning and capacity building in implementation of these activities. And we're so hopeful that the lessons learned in Malawi will be of great impact locally, regionally, and globally. I'll now hand over to Dr. Alex Kalimbira, who will discuss further on the impact of these activities in Malawi and beyond. Thank you very much.
Thank you, Bernadette, and I send greetings to all who are attending from different parts of the world. We have made tremendous progress from where we began in the 3 areas that my 2 colleagues have highlighted. And the question that I'm going to answer now is what's going on? What are we anticipating to happen in the future? Where are we going? Next slide. Yes, back up a bit, is it? Or next, sorry. Next. All right, so let's just go back a little bit and see where we were. Remember that we had 3 national priorities, which was the issue of growing overnutrition and nutrition-related NCDs. Another national priority was gaps in terms of nutrition education, social mobilization, and positive behavior change, as well as having an enabling environment for practicing nutrition. Next. Then through a number of gaps that were not noted, we implemented several activities. And just to bring you back a little bit to understand the gaps, lack of skilled dietitians was a key issue that was identified by the government of Malawi and partners with whom the dietetics program was implemented. The unknown nutrition competencies of medical graduates, as has been highlighted already, and lack of nutrition content in pre-service medical education. And of course, lastly, lack of country-specific nutrient availability of foods. And so in terms of activities, it's the 3 that my colleagues have highlighted: postgraduate training in clinical dietetics, the review of the medical nutrition curriculum, and also the development of food composition tables. So now today, as Dr. Chimera has just indicated, we have dietetics professionals who are in practice. We have graduated 2 cohorts, one of 4, the other one of 6, and all of them are in practice. We now have a strengthened multidisciplinary practice in terms of dietetics and growing the same in nutrition. And also medical doctors being able to better understand nutrition in terms of pre-service training. And now we have the food composition database, which is currently in use. Next. Now, when we look at the impacts, what have we achieved? In terms of impacts, we are looking at 3 levels. Number 1, because we had a national priority in terms of prevention of and management of overnutrition and nutrition NCDs, and therefore leading into the training of dietitians. Now we have an increase in human capacity for clinical nutrition. We understand as a nation that we're only talking about 10 locally trained dietitians for now, but these are in the tertiary, in 4 tertiary hospitals in our country, and already are filling an important human capacity gap that was there. And looking forward, as we continue to train more, then they'll go to district hospitals and be available to the Malawi population. The second one is that now we are going to have improved enabling environment to be able to respond to the different nutrition challenges that are there in our country. Either taking it from medical training or through the capacity that we are building at Luana, and also the College of Medicine started a dietetics program. And thirdly is the generation of tools and evidence for evidence-based practice. Right now, because we have the food composition tables reflecting many locally available foods, what it means now is that we have tools that are available for us to engage in different kinds of research that would help us perhaps to come up with some kinds of interventions at community level or even at national level that are based on our knowledge of what's in the food that we eat, what's in the food that is available in Malawi. Next. Now, when you look at this, the progress that we have made as a nation, I would like to highlight 3 levels at which the human capacity has been strengthened. Number 1, at the individual and institutional level. Today, as I speak, we have dietitians that have been trained, and a new cohort is going to begin next year. This wasn't there several years ago. Now Malawi has locally trained dietitians and will continue to train more. And number 2 is that now we have clinical curriculum development and implementation. Malawi now has a capacity to be able to put brains together and develop a competent curriculum that can withstand international, that is of international repute, because our dietitians do take an exam, a licensure exam at the end of their training, and that exam is contributed by many experts from different countries around the world. And then also we do have a database that is there where we can generate ideas, where we can generate the food composition, the data for the food composition, and put it together and be able to use that in different levels at country level and also at the individual level. So at the end of the day, what you're looking at is you're looking at institutions, the Luana and Kuhe, Lilongwe University of Agriculture and Natural Resources, Kamuzu University of Health Sciences, and many other institutions that didn't have this capacity before, but by implementing this program, now there is capacity at individual level and also at institutional level. Let me move to the country level. At country level, we now have a capacity as a nation to mount dietetics program. This wasn't there, we didn't have the capacity, now we do have it, and we're now moving into improving the current program that we have and making it better according to the reviews that we are currently doing. We now have a national food composition database, and I can indicate here that a second edition of that is under development right now, focusing on recipes. And one other thing that I need to indicate at country level is that by having the capacity that has been built in these ways through the Innovation Lab, now, for example, Luana has received funding to be able from USAID to continue to implement the postgraduate diploma in clinical dietetics. Because we have something that we have demonstrated we're able to do, we have received new funding to be able to move forward to continue to implement the program for the next 4 to 5 years. At regional and I would say global level, we have now models for implementation of dietetics program, at least in this region. And we have, as Bernadette indicated, an adaptable framework for medical curriculum review that other countries, other medical schools can take and use and improve the nutrition training of medical doctors in their countries. And of course, also we do have now the food composition table developed, and the processes that we went through are a model even for other countries that may not be able to have the same. I can indicate here also that because we have the local food composition database, a project that is based, a collaborative project funded by Bill and Melinda Gates. It's mostly based at the University of Nottingham, but in partnership with London School of Hygiene and Tropical Medicine, University of Addis Ababa, and also Lilongwe University of Agriculture and Natural Resources. We have a project which is called Micronutrient Action Policy Supply. That project is out there to use the local national food composition database to develop a tool that can be used to predict micronutrient intakes, to predict outcomes, and to help in terms of public health nutrition responses. This we didn't have then, but since now we have the database, it has been used in this project. Next slide. I would like to conclude by having this quote that one of our graduates, his name is Humphrey from the first cohort, indicated, and I read, "My overall feeling is honor, and I'm very excited to be one of the pioneers of this program in Malawi. I feel extremely happy to be a dietitian trained in Malawi because to me, I feel the best dietitian for Malawians is a Malawian dietitian trained in Malawi and who can understand what Malawians want for their health." When you hear this coming from a person who is in practice now, it just gives us extra energy to move forward and to make more Humphrey Chatengas for the people of Malawi. Thank you all for listening, and I take it back to Liz. Thank you.
Thanks so much, all of you. We've learned about what the challenges are in Malawi from a nutrition perspective, the government priorities, and how we've answered that through dietetics, through dietitian tools, and also through the education of the medical doctors. So we have some questions rolling in, and the first one, and we just have a few minutes, so I am going to try to stick to just a few questions. Sanele and Bernadette, I was hoping that you could describe the growth. So we talked about dietitians practicing in the hospitals at bedside, and that's sort of what we focused on. But what about community spread, outpatient, clinics? You know, how is that, schools? How is that going to happen? And maybe it's also through an association. So Sanele, would you go first?
Yes, quite right that we've been, where the dietitians have been deployed right now is mostly been at tertiary level, meaning at hospital care. And certainly there are plans for, to decentralize them and to get them down to district level, to primary health, to communities, to schools, as you've described. But that is also contingent on how well we can train more dietitians. And as Dr. Kalimbira has said, that is a key thing that we're going to be prioritizing over the next couple of years, training more dietitians through this additional grant that has been awarded. So it'll be about cascading down more. So right now, I would say that what we have is capacity, even at a hospital level, what we have is dietitians that are stretched indeed, I must admit, because there aren't that many, but they do manage to touch on, say, outpatient clinics, not just the clinical work, doing what they can with the resources that they're provided. So the plans are there, but it's all contingent on keeping up the momentum, training more and more dietitians and building that critical mass that can cascade through the levels of healthcare. That's my answer.
Thanks. A 1-second answer, Bernadette, anything to add?
Liz, I think it would be very great to coin this as the genesis of dietetics practice in Malawi, as someone who has previously practiced where there were no dietitians. And what I can say in response to what is your question of what's next and what is growth looking like, I would say that what the current project has left behind is no longer a gap, but an opportunity for growth. When I see now in the medical community, a doctor asking to refer a patient to a dietitian or to ask for a dietitian's contact within the hospital, I now know the impact and the potential for growth. The demand is there, and like Sanele says, we look forward to creating the critical masses. I hope that was 1 second for you, Liz.
That's great, thanks. Alex, what's the capacity? How many dietitians can we graduate in cohort 3 and 4 and 5? What do we have to look for the future?
And so the capacity that Luana has right now is that we are limiting to an intake of round about maybe 10 applicants every year, because we need to, as we are developing the capacity of the nation in terms of dietitians, we are also making effort to develop the capacity of the university, Lilongwe University of Agriculture and Natural Resources, to deliver. And so because of that, we are looking at no more than 10 dietitians registered and who can be pushed out into the system every year. And we're yet to see what the next cohort is going to look like. So it's a slow motion, but we are surely going there. Thank you.
Thank you. And we're out of time. I have more questions, but we are out of time. Thank you so much, all of you. It was a pleasure to be the moderator for your wonderful presentations. Thanks so much.